Hello and welcome. You're all very welcome to the first webinar in the webinar series being organised by the HRB Primary Care Clinical Trials Network Ireland. We're recording this webinar and it will be available on our website later this afternoon. My name is Edel Murphy. I'm the Development Officer with the network, and before I introduce and hand over to today's presenter, Professor Andrew Murphy, I'd like to draw your attention to a few aspects of the Zoom technology that we're using for the webinars. As this is our first webinar, we'll take a few moments to familiarise with the technology. You can access the webinars from computers or smartphones or iPads. There's a slightly different layout on each device, so I'll keep the technology overview fairly general and hopefully you'll be able to pick it up on your own device. Okay, so first of all, congratulations on managing to access the slides. If you're hearing me and seeing the slides, you've managed to register and download the Zoom app. So that's good. And this is the way we'll do it for every webinar. Downloading takes a few moments for the first webinar. Accessing will be faster every other time you join us. The second bullet here is for those who can see the slides but can't hear me speaking. They just need to make sure the audio on their device is switched and working on, is switched on and working. So hopefully if that applies to you, you'll be able to sort that out. We aim to make these webinars as interactive as possible. So the online chat is going to be important. So I'm just going to send you a quick message here and you should see it coming up on your screen, which will show you how to access the online chat. So during his presentation, Andrew will present treatment options and invite you to use the online chat. So maybe now if you could just type in your name and your practice if applicable and press return, just so that we know that at least some of you have tuned into the online chat. So I'll just give you a second to put in your name and send a message on the online chat. If it's not popping up for you, if you roll your mouse over somewhere at the end of your screen, there should be a chat option. Okay, thank you, Brian. We can see Brian Cahl has joined us from Grange Clinic, and we have somebody else coming in, Breda and Sinead. Okay, this is good. People have found the online chat. If there's anybody else who's struggling with it, the controls are towards the bottom of your screen or the top of your screen, depending on the device, and there's a chat facility. So we'll use that as we go through the session. Depending on the device you're using, you may need to actually click on close to get rid of the chat so you can see the slides again. Finally, I would like to point out to you that if you have a camera on your device, you can choose to have it switched on or switched off. There's a start video option in the controls, and if you click on it, as I'm doing now with mine, you can see that you show up on the picture. However, everybody seeing you can see you when you have the video switched on. We're conscious that this is a lunchtime seminar, so given that you might want to eat lunch during your seminar, feel free to leave the video switched off, but just that you know it's there. We don't plan to use the microphones today. In terms of CPD points for the webinar, we have applied for CPD points and we'll let you know in due course how to get approval. There's a little bit of a backlog with the process at the moment. I'll now introduce our presenter for today, Professor Andrew Murphy. Many of you know Andrew, who's been Professor of General Practice at NUI Galway since 1997 and is also GP in Turlough, a practice about 15 kilometres outside of Galway City. Andrew is the director of this Primary Care Clinical Trials Network, and in addition to being a GP and a lecturer in primary care at NUI Galway, Andrew has an outstanding track record as a researcher of international renown. Andrew has led trials evaluating the role of GPs in A&E and the management of cardiovascular disease, chronic pain, COPD and urinary tract infections, as well as leading many other research studies. So over to you now, Andrew, for our first webinar.
Thanks very much indeed, Adele, and that's a very nice introduction. You've never said such nice things about me before, so most appreciated. So this is the title of our slide. I'm very conscious that we're talking during lunchtime, so I do endeavour to be finished by about 1:45 on that time. It depends how much chat I guess we have. And that's what we're looking at. The objective of these network presentations is to give a little bit of clinical background and common conditions, and then to also note what trials are going through in the network in relation to that topic. Just to give a little bit of background on the network, it was funded by the Health Research Board almost 2 years ago. There's 4 trial networks in Ireland funded. There is stroke and newborn babies, and ourselves, and I've forgotten the 4th one. And what we're looking at today is the education and training bit. There's a number of trials that are being directly run through the trial, through the network, a number of other trials that we've attracted. And again, we're looking for people to be involved in these. So if you see anything that is of interest to you, please do contact us. Every Friday, close to the summer solstice in Galway, there's a race around the Aran Islands. You leave the docks at about 10 p.m. and hopefully arrive into the Aran Islands around 6 in the morning. Unfortunately, about 6 years ago, it was awful weather. We probably shouldn't have gone. So this is off the north tip of Inishmore, and it's actually a colour photograph at dawn. And when we went to the top of the waves, that's what we could see. So often it's difficult in clinical practice with everything's going on to sort of see the lighthouse for the waves. Hopefully at the end of this you will be seeing a bit more lighthouse than waves, but you can give us feedback on that. What I hope to achieve is to go through interactive cases, and the interaction will be through the texting. As Adele says, we had hoped to clarify that we will be getting points for this. Certainly for internal points, if people mention cases that they have themselves, I think that would move it towards that, but we have to get clarity from the ICGP. So we will be getting points, internal or external will be up to them a little bit. And then we will introduce the pursuit of perfection, is perhaps a somewhat smug way of referring to the research trials that are ongoing at the moment. So why simple urinary tract infections? Because it's common and important, and I don't need to stress these points to the audience that we have here today. It's certainly very topical. Just in 1 2-week period at the start of this year, I just scanned at the media. So here's the new scientists saying what's going on. Here's the New York Times. What I particularly liked on this one is, if you look at the top right, you can see that they say Trump is a Chinese agent. So certainly current affairs at the moment might suggest they were ahead of the posse. And then if you want a big headline, the Mail Online is the only place to go. Scientists are supercharging antibiotics. So I hope we're all using those supercharged antibiotics. But there's no doubt that what we do in practice really makes a difference. This is a very nice study from David Mant, who's a frequent visitor to these shores from Oxford. We all know that after prescribing trimethoprim, patients will initially be resistant perhaps for a month or so. But what this trial really elegantly showed was that when we prescribe in practices, up to a year after the prescription, patients are 33% more likely to be resistant to whatever antibiotic we gave them. So what we prescribed really does matter. And how do we prescribe in Ireland? This is data from the European Centre for Diseases Control. In 1986, just when I was a medical student, Ireland didn't have any data on the amount of antibiotics we were prescribing. In 1996, we were middle of the road, in the yellow road there. And then in 2006, we're still very much the same. Of interest with these is that the denominators have changed. So in actual fact, if one looks closely, and I should have said this presentation will be up on the website if you want to have a look at it again, is that we are prescribing much more than we used to, but the barometers have changed. It's as if the BMI indexes, we've changed the goalposts for. So although we're middle of the road, we're not as bad as Southern Europe, we certainly are in there. And that's quantity. What about the quality of what we're prescribing in Ireland? So again, for every 1 narrow spectrum antibiotic like trimethoprim, we prescribe 7 broad. So about 12.5% of our antibiotic prescribing is narrow. Compare ourselves to our neighbours who have 33% of narrow spectrum. So we're not doing so well on the quality. But thankfully, there's always Italy. So you can see with our Italian colleagues, only 1/238 is narrow. So again, we're not top of the class, but we're not bottom either. So let's move to our cases then. So these are all cases from the practice in Turlough. All pictures are taken from the internet. 17-year-old, attention for the first time, 2-day history of dysuria, urgency and frequency. Urinalysis suggests positive nitrite and leukocytes. No allergies. What do folks think they'll suggest? So I'll just leave you type away there. And again, for your points, it is important to try and type on this. So let's see what folks are thinking as regards what to do in a situation like this.
Okay, so if everyone would like to use the online chat to make some suggestions, that would be ideal. A, B, C, D, or E.
And perhaps a comment as well. It's really more about the discussion points is the key bit rather than, it's not an MCQ. No negative marking, you'll be pleased to hear. Okay,
so we've one suggestion coming in for B, a few suggestions for B coming in.
So certainly nitrofurantoin is recommended together with trimethoprim and a new person on the block, fosfomycin, by the Irish prescribing guidelines. Fosfomycin is widely used in France. We haven't tended to use it too much in Ireland, but it is growing in popularity. Interestingly, the company for it have put very little push really into trying to move along with it. And that has been a change really, I think, is the introduction of nitrofurantoin. So who I'll be quoting are the Scottish Intercollegiate Guidelines signed. They're very well regarded guidelines really from the diagnosis point of view, what's of interest is that if you're below 65 years of age and have three main symptoms, they suggest we don't do urinalysis at all. We just go ahead and treat empirically. Obviously with females, vaginal itch always raises the concern about either thrush or STIs. And only, again, we're very fortunate in Galway in that we have an excellent microbiology department who will take as many MSUs as we send to them. They are interested in looking at what is the practice surveillance of resistance, and we'll have a look at that in a moment. But again, in the UK, they don't have that facility, and MSUs are much more restricted.
And Andrew, just a question coming in here. Can you advise on length of treatment?
So again, that's an interesting change from it. Both the Scottish guidelines and the Irish guidelines do suggest 3 days duration. That can appear short, and certainly I think in clinical practice, people, if they have any concern about the overall health of the patient, will go for a little bit longer. But perhaps for a 17-year-old fit student, 3 days is probably appropriate for that. Again, in Scotland, interestingly, for upper urinary tract infections or pyelonephritis, they do suggest some guidelines for not admitting patients. Again, that might be a little bit different to practice here. Of interest, we'll be talking about a German trial towards the end of the discussion. And of the patients with pyelonephritis in that trial, none were admitted to hospital. So perhaps a little bit different. Worth just zeroing in on nitrofurantoin. Certainly when I was going through medical school, got a little bit of a bad rap as regards nausea. Again, there's not anybody promoting it hugely, but that is the recommended doses. The macrobid, the twice daily, can be difficult to get. It's not routinely available in practices, and certainly the pediatric dose is very expensive and often not available either. But the big thing about it, as we'll see, is resistance is very low on it. It can be used in pregnancy, but should be avoided in late pregnancy. But as the Scottish guidelines suggest as well, it doesn't work as well if renal function is not optimal, and that is less than 60. So it does need to be watched in the older population. This is some very nice work by Aka Velinga, who's in the department, and I think online at the study as well. So if Aka, if I say anything wrong, you can type in and correct me. This is a very nice study that Aka did based in the Galway region, in which 22 Irish practices through electronic upload submitted all their urine samples and prescribing patterns for patients with suspected urinary tract infections. I've just highlighted two practices there, 14 and 3. These are completely anonymous, so I have no idea who these practices are. And I'm particularly interested in the green and the, what would you describe that? Pale blue colours. If we look at practice 14, firstly, almost 80% of people with suspected urinary tract infections get antibiotics, and the primary choice of antibiotic was a quinolone. Compare that to practice 4, which had almost only 40% of people with suspected urinary tract infections getting antibiotics, and the vast majority getting nitrofurantoin. So like everything in practice life, there's huge variation, and we're not surprised by that. But back to that slide from David Mann's group, showing the impact of our prescribing on individual patients. In practice 14, where ciprofloxacin or the quinolones dominated, it has the highest percentage of resistance to quinolones. And compare that to practice 5, which did not prescribe quinolones. There's very little prescriptions to that, antibiotic resistance to that group. So in this short-term cross-sectional study, the impact of what we prescribe makes a difference. And certainly we probably in Ireland do need to increase the amount of nitrofurantoin, trimethoprim or fosfomycin that we're using. In our own practice in Turlough we can't prescribe trimethoprim. We know that the resistance rate to trimethoprim in our practice is above 20%, and according to guidelines, once an antibiotic goes above 20% resistance, we should not use it. And again, all of you can get your own prescribing profiles, and resistance profiles from, certainly within Socrates network, by just clicking a button, and that's an audit that's available, and I'll be referring to that later on. So again, the outcome here for this patient was that it did grow E. coli, which we'd expect. It was sensitive, and she settled down very well. And as often in this age group, there was a question about sexual activity, which I was about to raise, and the patient's mother literally jumped into the consulting room at that point, wanting to know what was going on. So again, it often is a door entry to other features. So next patient then would be an older patient. This is a picture of a happy 84-year-old. I looked for that picture. That's what the Google said to us. Like so many patients, complicated, has renal failure. EGFR is okay, on lots of other medications. What this patient is picking up on is we often do have results of previous MSUs, and how much faith should we put in them? So we haven't sitting in front of us that 3 months ago she did an E. coli infection, which was resistant to trimethoprim and comoxiclav and sensitive to ciprofloxacin and nitrofurantoin. So can we still rely on that? So over to you. With that sort of a resistance pattern, will that impact on your choices? How predictable are the resistance patterns from 3 months ago? So over to you to type away.
Okay, so we've one suggestion for A, the nitrofurantoin, and somebody else saying B.
Okay.
And a couple of A's and a couple of B's, yeah.
Great.
And a
okay.
D, fosfomycin is an option.
Good. And again, just recently, in the last 2 days, the laboratory in Galway is now routinely checking sensitivities for fosfomycin as a first-line agent, which I think is really interesting on that, so that will be readily available. So again, this is work that Aka Villing in the department led on. Was just simply looking at in the laboratory in Galway, if you had 2 samples of urine 3 months apart, how good are they at predicting resistance? And really, I think these findings were quite interesting in that it showed clearly for nitrofurantoin that resistance, even if they're resistant 3 months ago, it drops down to 20%, unlike the others which continue to hold on. And again, my good colleague Martin Corrigan would put this down to fitness cost, all the way back to our CRED cycle, that the amount of energy required for the organism to hold on to resistance is very high for nitrofurantoin, not so high for others, so therefore it tends not to hold on to it. So again, it suggests highly the strong role for nitrofurantoin. We're conscious that this patient has mild kidney failure. We maybe have to take that into account, but that is the point. And whereas with sensitivity, if bugs are sensitive, it's highly likely that they'll continue to be so as well. Outcome for that patient settled. Sometimes we do send a check MSU. Even Martin, who, as I said, who's incredibly liberal, I believe, in his acceptance of urine samples from us, would suggest not. Something that we don't have time to go into today, but I think is a very interesting issue, is prophylactic antibiotics. If we have time at the end, I'd be delighted to discuss that with folks. That's not in the signed guidelines. It's another Scottish Medicines 2-pager, and that's an excellent document, I think, talking about prophylactic antibiotics. But we could come back to that if folks like to. So then, let's move on to Mrs. Kavanagh then. 3 days ago, vague history, no GU symptoms, bit of leaking urine, sample sent, and as often happens, we get landed then with the results. So the results do suggest an infection, which is quite resistant. So back to your typing now to earn all those points. No such thing as a free lunch. What are your thoughts for her? So let's just flick backwards. So sort of vague history, unwell, but there is definitely leaking urine, and the sample is growing something. What might we think of in that situation?
Okay, so we're getting some suggestions of A, refer from management, or B, nitrofurantoin, or A and B, a few A and Bs coming in.
Good. So again, you know, A and B suggest the pragmatic nature of our discipline, which makes a lot of sense for it. This is actually not from the SIGN guidelines, but is very much consistent with them. It's a paper that Martin Cormack led on the BMJ looking at asymptomatic bacteria. And it does refer to bacteria at significant levels without any symptoms suggested of a UTI. There's no focus. So stress incontinence is not a symptom suggestive of urinary tract infection. It's very common, particularly in nursing homes. It is of clinical importance in pregnant women only, but not in other categories. So that we should not treat it apart from an impregnant woman with it. So for her, without any treatment, tiredness cleared up and she was happy to go on as she was. So it is an issue, I think, particularly in older populations where we're concerned about overprescribing. Next up is, again, long-term catheters in general practice is an issue that I think probably hasn't received a lot of attention. It's one I'd certainly be interested in looking at a bit more. If others were interested in identifying patients, I would like to do a bit more. So typical of these patients, a 57-year-old with MS, long-term catheter, and changed it last week. Called back again to say he was unwell. This patient looked acutely unwell when I saw him. I did a dipstick, and we can talk about that, and it showed up Piccadilly Circus, everything going on there. I wanted to send him to hospital, but he wouldn't go, basically. So options that are there, again, type away and tell me what you think. Background is pretty well, otherwise I think a bit of hypertension, nothing else. Unfortunately, chronic remitting relapsing MS, which really has been very difficult for them all. So those are the options. He certainly was unwell, you know, not falling out of the bed, but I felt needed to go, but he wouldn't go. So Adele?
Big mix of suggestions here. Some saying send your urine sample to the lab and either nitrofurantoin or ciprofloxacin. Others going just for drug treatment, or in some cases C and D.
So again, I think that does reflect the Scottish guidelines are good here, I think, in that they do cover this. So often it isn't covered. And it's interesting what the Scottish guidelines say is it's more about what not to do than what to do. So that we shouldn't do what I did, which was dipstick testing. They say it's completely unreliable. If you dipstick anybody with a catheter, you're going to get stuff in. So it's just not reliable. They present very differently symptoms-wise, so we need to be aware of that. Antibiotic prophylaxis is not recommended in this group. We can come back to that. If we are going to give them antibiotics, we need to change the catheter that's in there. I did do that, but we'll see what I did in a minute. And that the choice of antibiotics is a local policy. Nitrofurantoin does not work for catheterized patients. The bugs, it doesn't work well. It works well for gram-negative bugs, but you're probably going to get something different with a catheterized patient. Protease, it doesn't work against Klebsiella. So nitrofurantoin is not recommended for patients with catheterized. And it's at least 7 days, but up to 14 days as well. So quite a push out compared to the simple, uncomplicated patient that we had at the start. So they actually didn't end up in hospital despite their best efforts. They had a very nasty bug that was not going to respond to oral antibiotics. The catheter that I put in was not correctly positioned, they would claim. I would claim to my last, I put it in, soft feedback, blew up the balloon, but it was in the urethra, they said. So moved on to a suprapubic catheter. And it's done actually well with the suprapubic catheter on it. So this is our last case. I'm just conscious of time. And again, we've moved into another male. Uncomplicated urinary tract infections, by definition, are in females. Males do not have simple, uncomplicated urinary tract infections. Again, my colleague Aka has done nice work looking at urinary tract infections in males. It's an area that's not often looked at. So let's look at Bert, 67-year-old ischemic heart disease, significant urinary frequency and pain. He's not a complainer, Bert, know him well, so thought that there was something going on. Obviously, with any presentation like this, the issue of sexually transmitted diseases comes in. Again, Bert says no on that. Rectal examination and urinalysis is normal. Just this is interesting, is that I Googled what does a happy 67-year-old male look like, and this is, according to Google, what a happy 67-year-old male. I don't know what the Los Angeles Times has to do with it, but there you go. Interesting what Google throws up. So what are you going to do for Bert, a 67-year-old male with urinary symptoms? Send an MSU, prescribe a quinolone for a fortnight, refer all men, encourage prostatic expression. So I enjoyed that phrase, prostatic expression. So what comments, type away there. This is the last time you'll have to be typing. And I think I've put the wrong number in on top of that, actually. It's number 6, isn't it?
Okay, so we're getting suggestions here of both A and C, or B, prescribe the quinolone for a fortnight. Yeah, 2 B's and A. Yeah, so mixture.
Mixture as well. And again, as somebody who sets MCQs, we like to see ranges because it suggests that it's a well-performing question. So sign, again, just that preamble, is that these are regarded as complicated urinary tract infections. Males shouldn't, because of the length of the urethra, they shouldn't be getting urinary tract infections, so we should consider sexually transmitted disease, particularly chlamydia. Interesting point is that we think of a urinary tract infection as a binary measure, either they have or they don't. That is under pressure at the moment. Europe is moving towards a much smaller 10 to the power 3 rather than 10 to the power 5. But the UK is sticking certainly to 10 to the power 5, but even there they are suggesting in males that 10 to the 3, as long as they have a single organism, does suggest a urinary tract infection. But they do suggest that prostatic involvement is often a key role here, and that nitrofurantoin is poor at penetrating the prostate, so that a quinolone would be recommended if you felt that there was a prostatic element here. And we doesn't suggest that we have to send everybody to urology. Certainly if they have recurrent urinary tract infections or they fail to respond to appropriate would be reasonable. So that concludes our cases, and again, please do send in any other notes that you have on those. We'll just finish up quickly on the pursuit of perfection, which, as I said, is probably inappropriately labelled, but just to let folks know as to what's going on through the network as regards study trials. So first up is a look at symptomatic versus antibiotic treatment for urinary tract infections. This is led by my colleague Aka Valinga, and it's, I suppose, a progression on the previous work that the department was involved in. The Germans did a trial that was published in the British Medical Journal that used brufen or phosphomycin to patients with uncomplicated, and I should stress this is not sick patients, it's not male patients, it's not patients who are extremely anxious. It's people who, when faced rather like sore throat in that scenario of would you be willing to consider not taking an antibiotic. And what it showed is that after 7 days, everybody ended up roughly where they should be without too much pain, but that it did take about a day longer for patients on the brufen to get there. Of interest was that obviously there was much less prescribing going on in the brufen group compared to the phosphomycin group. And that of key interest to us all is pyelonephritis. There were 6 cases, 5 in the phosphomycin group, 1 in the 5 in the ibuprofen group, I should say, 1 in the phosphomycin group, and all did fine and didn't have to be admitted to hospital. So satin is a development of this study. It's a little bit more clear as to which patient should come in. There's a more clear safety net on it, and that is just beginning to be about rolled out into 2 practices in Galway. Practices must be affiliated to Galway to be involved in this study, because we're looking at the microbiology there. But that is being rolled out, and it's the first controlled trial that's under regulations because it is a new use of our product. So that's a very exciting development. The second area I think that's interesting is penicillin allergy. As we're all aware of the difficulties of being definite about penicillin allergy, although the fact that it's the most commonly reported drug allergy, but it does push us and patients down a route of avoiding penicillin, which unfortunately may have impact, as we've seen. If you start to use the higher up antibiotics, you have a higher risk of getting resistance to those. So a colleague, Hilary Allen, is doing a master's through the Imperial College in London and is just doing a paper exercise and looking at patients who were recorded as having penicillin allergies and trying to determine through a paper protocol what is their risk of doing it. So again, if people are interested in that, and that doesn't have to be associated with Galway. This is the group that started off 6 years ago in Galway, a happy hippie group around 9 o'clock heading out to Galway. And this is the group then about 10 a.m. the next morning, battered and bruised. And certainly a number of these people never went sailing at all. This individual headed to Canada the next week to as far away from water as he could get. This man took up golf. So I hope we haven't caused as much disruption. We had our successes. This guy here became a lead sailing instructor in Howth and funded his university education on the back of that. So we do have some successes on things. So hopefully you can see the lighthouses now rather than the waves. Key take-home messages: nitrofurantoin, your only man, except for catheters and maybe phosphomycin. Know your practice resistance profile. Again, work that ACA did on the, if you're using Socrates in the IPCRN folder, you simply have to, if you code your urinary tract infections with U71, the ICPC code, you can develop a profile and that can do an audit for you. If you have any queries on that, give us a shout, and that's available there. And do not treat asymptomatic bacteria except in pregnant, and do consider the pursuit of perfection. So I'm very conscious that this is people's lunch hours. I'll just finally finish by saying we are having our inaugural GP Network meeting in the Radisson in Athlone. We've decided for that venue just because of its central location. Friday night, Saturday morning. Very much just about sharing about the network and hearing perspectives, ideally from practices, about how we can promote more trials in your practices. And if you're interested, just contact Adele, and obviously overnight accommodation, dinner and everything is taken care of. So thank you very much indeed for taking part in our webinar. If you have any general comments or suggestions about this series, please do get in touch. We would be delighted to hear from you. The next webinar is due to be on Wednesday, the 25th of November. Susan Smith is going to be talking October, so Wednesday, 25th of October. At lunchtime again, Susan Smith is going to be talking about multimorbidity, hugely common and important as well, and trials that she's rolling out, which are again available nationally. One doesn't have to be in one particular location to receive those. So Adele, I'm not sure if there are any complaints or solicitors' letters in at this stage. Are we good to wrap up?
No, I think we're good to wrap up. Thank you very much for everyone for joining. We are very interested in your feedback and the capability for interaction. So please do drop us a line on that. So thank you very much. We'll stop recording now. And just for CPD points then, we'll send out certificates to people, but we will need to know your name and address, and I presume we can pick that up from the emails there. So yes, we can indeed. Yeah. Okay, thanks a lot. Bye-bye.